Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm a proud preemie parent and a former journalist, and I'm happy to be your host today, live from Halifax, Nova Scotia. I'm so honored to have you join us here today. Preemie Chats is brought to you by the Canadian Premature Babies Foundation. You may also know them as CPBF. It's a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. So whether you're a parent, a healthcare professional, a researcher, or someone interested in understanding more about preterm birth, you're in the right place. Together, we're building a supportive community where stories are shared, questions are answered, and new evidence is explored. And most importantly, no one feels alone. I'd invite you to visit our website. It's there on the screen, CanadianPreemies.org, and there you'll find lots of free, helpful, up-to-date resources, our latest projects, and most importantly, a community of people who want to see our little babies thrive. If you are watching live today, I'd invite you to please join the conversation. Share your questions and comments in the chat, and we will address them during our program today. And if you're watching a pre-recorded session, you can still connect with us through our website. It's through meaningful discussions like this that we advance practice and learn together and grow together. So please let us know in the comments where you're watching from and your own experience. We'd love to hear from whoever is taking part in today's chat. Today, we're doing almost a part 2 of what we talked about last week. And so if you missed last week's, you can catch up. You can watch it on our YouTube channel or on the website. If you it's okay if you missed last week because you can still pick up on this conversation. It's a topic that affects all NICU families, all families with premature kids. It's feeding in NICU. So last week, we really focused on the mechanics behind feeding. And our expert also reminded us, I loved the messaging behind oral feeding, that it is a skill and that it takes time, and that many parents, even of term babies, don't have a straightforward feeding journey. So just remind yourself of that. This week, Dr. Sandra Fucile is going to share practical, evidence-based strategies that may help you and your little one with your feeding journey. Or if you're a healthcare provider watching today, it'll give you some insight and tips in helping families feel confident and supported in their feeding journeys. Sharing her wisdom and guiding our discussion today is Dr. Sandra Fucile. So she's a registered occupational therapist and assistant professor at the School of Rehabilitation Therapy with a cross appointment in the Department of Pediatrics at Queen's University. She's passionate about giving every infant a bright start and has dedicated her research towards enhancing the health and development of infants born with complex medical conditions, with a particular focus on those who are born preterm. She leads the Infant Neurodevelopment Feeding Advances and New Technologies, or if you caught that acronym, it's Infant Research Lab, located at Kingston Health Sciences Center, which consists of an interdisciplinary team of students, clinicians, researchers, and families conducting clinical investigations aimed at promoting the well-being of infants and their families. Thank you so much for joining us again today, Sandra. I'm so excited for part 2 of this chat.
Yeah, my pleasure. I'm happy to be here.
I will let you get right to it today.
Great. Thank you, Leah. Thank you, everybody, for joining me once again for this week's session. And the goal for today is really to provide an up-to-date on pre-feeding interventions. What's the research available on them to enhance the oral feeding skills of infants who are in the NICU? And this is one of my main areas of research, and before I get into my talk, and it really stems from my clinical practice, whereby oftentimes we were called when there was a problem, and I felt, is there something we can do beforehand? And a lot of what I present today is, what are those interventions that we can do before we start breast or bottle feeding to help maintain the skills of our infants? So I have no conflict of interest to disclose, and no financial compensation was received for this talk. And for the next 20 minutes, I'll provide an overview of what's the current management, speaking specifically within Kingston Health Science Center, which may be applicable or not to the unit that your infant may be in, or the practice that you are practicing in. And then I'd like to give a bit of historical about where this early intervention idea stems from, where this preventative care model stems from. And then lastly, close off with different intervention strategies we can use and what's the evidence on them, and really an up-to-date on the evidence on these early intervention strategies. So I alluded to it earlier. Right now, the current management of oral feeding for infants who are in the ICU is a reactive care model. Babies are born 8 weeks premature, usually are too young to start bottle or breastfeeding. And so they'll receive mostly of their feedings by tube. And then, based on either behavioral cues, weight, the teen decides to start bottle or breastfeeding. And as alluded in last week's conversation, is 20 to 40% of infants may experience difficulty with the transition from tube to oral feeding. And that's when they'll call the feeding specialist. And that's when the anxiety is increased for everybody, because oftentimes, like I said last week, it's a last milestone needed for hospital discharge. And so I started this journey over 20 years ago and looking, can we do something beforehand? We know infants start sucking in utero at 12 weeks gestation. Can there be something that we can do to prevent or to facilitate or optimize the transition from tube to oral feeding? And that's where my research stems from. And so I went on a journey to look for a model, for a preventative care model. Sorry for the typo. It's supposed to be preventive care model, not preventive case more. And I found a group of researchers who carried out studies with the rat model. This was done by Schonberg and Kuhn in 1960. And very briefly, what they found is if you have the rat pup, the mom, and the baby, and if they separated them, the baby stopped feeding, the baby stopped growing. And they actually looked at physiological measures and saw a decrease in growth hormones and other hormones. Then they did another study, and they put the mom and baby back and found that it reversed the above processes, that they started to feed again, they started to grow. But they also observed that the mother was constantly licking the rat pup. And then lastly, what they did is, let's separate the mom from the rat pup, the baby. And this time, the baby again showed failure to thrive, wasn't growing, wasn't feeding, but they simulated the tongue-licking behavior by a wet paintbrush. And they started stroking the rat pup. And that reversed the above processes. And that study really struck a chord with me, because a very clear parallel was found between the rat pup model and what infants in the NICU experience. And that's that physical separation from the mother, whereby they can't provide that constant bonding and touch. And so a lot of the studies in our lab have been conducted based on this model. And so when I refer to early intervention, and there's many different intervention definitions for early intervention, I'm really referring to in the lens of prevention. When I'm referring to early intervention, it's before oral feeds are commenced in order to maintain the rudimentary sucking skills and to facilitate the appropriate development of oral feeding skills. So I'm talking to you in that lens today, before oral feedings are started. And here is a list of preventative interventions or early interventions that are used clinically and have been researched. And so what we'll go through is, So what we'll go through is there are 8 interventions. I will describe to you the intervention, and then following the description, you'll see a table of what's the evidence. And so, and based on the evidence, I will tell you if it's strong evidence or not so strong or moderate. And then I'll have a summary table for you at the end for recommendations to move forward in terms of what families can do, what practitioners can do to help maintain the rudimentary feeding skills in infants. And so the first intervention is skin-to-skin contact. It is referred to as a practice where the baby is lie directly on the parent's bare chest after birth. It's also called kangaroo care or simply skin-to-skin. What is the evidence? You will see there's a star. When there's a star, that refers to this specific intervention has a systematic review done. What a systematic review done is one study that takes all the evidence and then does some analysis and then makes recommendation. So if we're looking, and there are many studies and there's many systematic reviews on skin to skin because it has many beneficial effects. I'm just highlighting the beneficial effect on feeding, okay, for skin to skin. So I'll draw your attention to the Moore study that was done in 2016. They did a systematic review, so they get a gold star rating because that's the best evidence we have. It looked at 38 studies. It had 3,472 infants in their systematic review. And they actually found that it has skin to skin has a positive effect in that infants were more successful at breastfeeding. And there was a longer duration of sustaining breastfeeding from 1 to 4 months. The caveat with this systematic review is that it was just for full-term infants. And so when I was putting this presentation together, I found a more current systematic review, and that's the one from Gupta in 2021. They also assessed the effect of skin to skin. It had 30, it's a systematic review, meta-analysis, 30 studies, and they found a positive effect in terms of exclusive breastfeeding, and it promotes bonding. And the exciting part is it was only 8 studies, but at least they had 8 studies on infants who were born preterm. So the evidence on skin to skin is fairly strong that it does facilitate the oral motor skills for feeding. The next intervention I'd like to introduce you to is the non-nutritive sucking. And there's 2 types of non-nutritive sucking. There's a non-nutritive sucking on a pacifier, and there's a non-nutritive sucking on the empty breast. There is a lot of concern from some parents in introducing the pacifier because there is some controversy in terms of does the pacifier interfere with breastfeeding or not. There's the Hospital Baby Friendly Initiative who actually stated that the pacifier for preterm infants is permissible, okay? We have found in our studies that the pacifier is actually a training. We have to keep in mind the babies are born early, and so they still do not have the skill set to feed, and that the pacifier provides a training. So let's see what's the evidence on using a pacifier for infants who are born early. Again, we have a star, so that's good. That means that there is a systematic review. And this was done in 2017 by Forrester. I don't have a more recent one. but this is the most recent ones I found. It looked at the effect of non-nutritive sucking on nutrition, on feeding. It had 12 studies, 746 infants that they performed a quantitative analysis. And they found that provision of a pacifier before oral feedings are started facilitated the transition from full tube to full oral feedings. It had positive effects on length of hospitalization, but it did not affect weight gain. However, overall, non-nutritive sucking on a pacifier seems to help build those oral motor skills for when it's time for the baby to breast and bottle feed. The other non-nutritive sucking intervention is on an empty breast. And what Leah referred to is it's sucking on a maternal breast after the mom is emptying without the ingestion of milk. There's a question mark there because there may be traces of milk. We know there are traces of milk that can occur when the baby's even sucking on a breast that has been emptied out. And that's okay if the baby's safe doing it. In terms of what's the evidence, there's no STAR, which means there hasn't been a systematic review done. To my knowledge, there's been 2 studies only done, and one of the 2 was a randomized clinical trial. And that's really considered the best of evidence if there's no systematic review. And that study was done by the individuals in my laboratory in 2021. And we looked at the effect of non-nutritive sucking on a pacifier versus an empty breast. It was on 33 infants. And we actually found that it enhanced direct breastfeeding at hospital discharge. And I'd like to extrapolate what that means, is that if you provide the infants with a pacifier or empty breast, both of them, when they were started oral feedings, there was an equal amount of them receiving the first feeding on the breast. However, when they got close to discharge, we found a difference between the group whereby the ones who received the non-nutritive sucking on an empty breast continued to do better and receive most of their feedings via the breast. And so that's an indication that non-nutritive sucking on empty breast really helps sustain exclusive breastfeeding in the hospital. There was no difference between the 2 interventions in terms of the transition from full tube to full oral feeding. The next intervention is referred to as oral stimulation, and that's the provision of sensory motor input to the so the outside oral structures, the cheeks and the lips, and inside the intraoral. This is commonly done by feeding specialists, either a speech language pathologist or an occupational therapist. Again, this is usually done before oral feedings are started with the idea that we help strengthen the oral musculature. It's like an oral exercise, so they're ready for breast or bottle feeding. We have a STAR here in terms of what's the evidence on oral stimulation. And that's a very recent systematic review done by Green in 2023. 28 studies were included in this review, 1,831 infants included. They found a moderate effect in terms of the transition time from tube to oral feeding. They also find a moderate effect in terms of length of hospitalization, and moderate effect on total parental nutrition time was reduced. So overall, moderate effect on oral stimulation programs. Another intervention that is done, and which is referred to swallow exercise. And this is the intentional provision of little drops of milk from 0.05 to 0.2 milliliters per day on the tongue where the bolus rests prior to entering the pharynx. And that's really to help trigger the swallow, like I spoke to last week about the suck, swallow, breathe, and to have infants practice that swallow exercise. But not only that, oftentimes it's done with maternal breast milk if it's available. So it really helps with that gustatory stimulation as well. In terms of evidence, there's no systematic review. To my knowledge, there's only 3 studies done. And 2 out of the 3 were randomized clinical trials. So the gold standard if there's no systematic review. A very recent study done in 2025 from Mostati, and a later study done by Dr. Lau in 2012. Both were comparing swallow exercises, so putting that droplet of milk once a day, to non-nutritive sucking on a pacifier. And in terms of what did they find, does it work? The study from Ostati in 2025 said that there was no difference between provision of a pacifier and swallow exercises in terms of being ready to orally feed. And the study from Lau actually said that the swallow exercise led to a faster transition. So the take-home message is this is a fairly novel intervention, not much evidence on it, and even the evidence we have is really not clear or suggestive that we should be doing this. It was really not clear, and that more studies are really needed to prove the evidence and the effectiveness of this intervention. So tactile kinesthetic stimulation. This refers to, remember, for those of you who were here with me last week, if not, I'll repeat it now, that the ability to an infant to suck, swallow, breathe entails a multitude of systems, including the postural control. And here's a non-oral intervention, which is the tactile kinesthetic intervention, and it is referred to put inputs to the trunk and limbs or passive range of motion of the limbs. What's the evidence? We have a STAR, and that means there's a systematic review done that looked at the effect of tactile kinesthetic intervention. It was actually, I take that back. It wasn't a systematic review, but a scoping review. So there was no data analysis. It's sort of a summary of the findings. It seems to facilitate the transition from full tube to full oral feeding and length of hospitalization. So if we do not have access to the oral area, if they're receiving high flow or there's discomfort when provision oral stimulation, tactile kinesthetic input can be provided as a complementary provision before oral feedings are started. And the last 2 interventions are olfactory. It's the provision of the odor of human milk. We have a STAR. It was recently done by Lee in 2024. 7 studies. It's in terms of effect, it seems to help with achieving full tube feeding, but there was no effect in the transition from tube to oral feeding. So it does not seem to have, the olfactory doesn't seem to have a positive effect on the transition from tube to oral feeding. And the last intervention is auditory stimulation, and then only focusing on the provision of positive sound, the maternal voice or paternal voice to the infant. A systematic review recently done, and there's inconsistent findings in terms of the effect on the transition from tube to oral feeding. And they emphasize that the findings go beyond what they were looking at in terms of transition from full tube to oral feeding. They actually found beneficial effects to the maternal well-being that was deemed, and I agree, important to consider. And so I realize a lot of interventions have been introduced to you today. And what are some take-home messages for families, for health practitioners who are listening? I realize we're all coming from different backgrounds, different units, and different access in the unit of different healthcare professionals, whether there's feeding specialists or not, lactation consultants or not. And in terms of my recommendation, skin to skin, as soon as deemed clinically stable that you can provide skin to skin to the infant, that would be the one with the strongest evidence, the one that does not entail an extra health professional coming in. The second strongest would be non-nutritive sucking on a pacifier. However, if your intention is to breastfeed, bringing this evidence to the attention to the team if that's not done in your unit, if you can work with the team members to to help establish this non-nutritive sucking on an empty breast. And the last one is the oral stimulation. If you do have a feeding specialist, to if you're health professionals, to call the specialist before feedings are started to provide this oral stimulation to help prepare the skills. And if you don't have a feeding specialist, we can talk about that after that oral stimulation program. We did test it for parents to provide intervention, but it's been adapted. And so my take-home message, top 3 interventions to advocate for skin to skin, purposeful non-nutritive sucking on a pacifier empty breast, or oral stimulation. And the other interventions really need much more evidence in terms of their effect on oral feeding skills. And I sign off with all my talks in terms of, as I said earlier, this is definitely a passion of mine. And really, there is no finer investment for any community than putting milk into our babies. Thank you for your time.
Thank you so much for that presentation. I feel like it went by so fast, and I was scrolling notes for my own benefit, but also questions. And so we did have a question as well from Sandy. Now she talked about kangaroo care maybe having a limit. So the kangaroo care has a limit. How can you achieve weight gain or keep premature infants stable in that kind of situation, I think is her question.
Yeah, so how soon to start, how long to start, where it's not. Sandy, I don't have the answer for you because there's no magic number, right? The babies all present very differently. Some babies tolerate it for a few minutes, others tolerate for 20 to 30. I think the messaging is, if you want to do skin to skin or kangaroo care, to ask the nurse, the bedside nurse, can we try? And if you try and it's just 2 minutes one day, it's 2 minutes. I think that goes further than not trying. And in terms of achieving the weight, if you notice a lot of the studies, that's a good question, did not find a difference in weight gain. In our unit and in a lot of units that I've seen, and I've been in over 5 units, is weight gain is very tightly regulated by the neonatal team, right? Every day they discuss weight, they do an average weight, and then the dietitian is there to up the calories, and they have all their magic formulas for weight. So if it's a concern for weight, it's so closely monitored that it should not be an impediment in doing kangaroo care, because we know it's closely monitored. And I really encourage to do it, even if it's just the first time for just 2 minutes. And I'll stop there. The benefits I think the benefits outweigh the risk of losing weight, and not to worry about losing weight because it is very controlled and tightly monitored. They're not going to let that happen. Does that make sense?
Yeah, it does. Yeah, and we always say, however amount you can do has positive impact. We do know that.
And there's a research says that too, Leah. Sorry to interrupt.
Yes, yeah.
The research says that too.
Exactly. You talked about 3 interventions that you'd recommend as kind of the top 3. Yeah. And so skin to skin, we touched on, the non-nutritive sucking we touched on, and the oral stimulation. So you had talked about needing an occupational therapist, or there was someone else you said who could help with that. Yeah. So is that something that families can learn or advocate for in NICU, and what does that look like?
Okay. Very good question. I'm happy you asked that, because I didn't have enough time to go into that. So oral stimulation consists of positive input to the oral structures. Again, based on that animal model, right? Remember our babies, I say ours because I consider them my babies in the unit, they start sucking at 12 weeks. That oral stimulation program, and there's different variations, but what we've developed is an oral stimulation. This was over 20 years ago, where it's 5 minutes of input to the outside of the structures, 5 minutes of input inside the oral structures. So that it's 5 minutes to the cheeks, lips, and the chin, 5 minutes of the tongue and inside the cheeks, and 5 minutes of non-nutritive sucking on a pacifier. And the intervention usually, Leah, it's done by an occupational therapist or a speech language pathologist. Some cases, some units, actually the physical therapist, because they don't have an OT who does it. And it's done once a day for 15 minutes. The idea, we do this before oral feedings are started. The idea is that we're providing positive input. If we do the intervention and the baby turns away, you stop, because the first time you do it, they'll turn away. But by day 3, they are loving it. It's 3 days. It takes 3 days for them to realize
that you're talking.
No, it's stroking. It's stroking.
Okay.
It's deep stroke. It's very systematic stroking of the oral structures. It's kind of it's not this. It's definitely a stroking, again based on the rat model, where it was stroking that found beneficial effect. That was done 20 years ago. It's been replicated. There's systematic review, moderate effect. What we recently did here at Kingston Health Science Center is we adapted that program. It's called a parent-administered sensory motor intervention. We adapted it because the provision of outside stimulation we felt parents can do, but inside the mouth, even for therapists, is tricky.
Yeah.
And we want it to be positive for parents. We replaced that with the tactile kinesthetic. So it's a 15-minute program provided by the parents, where they're stroking 5 minutes of the oral structures, 5 minutes of tactile input to the limbs, and then 5 minutes of non-nutritive sucking. And that has been just recently published. And we found that parents who were engaged in this program, who participated in this program, there was a dual benefit. The infants transitioned from tube to oral feeding sooner than the parents who weren't part of the program, who were in the control group. We also found that the parents who were engaged in the program, a greater number of them participated in breastfeeding throughout the hospitalization. So that's telling us that having that early, consistent contact, purposeful contact, where parents are feeling I'm making a difference for feeding, we felt maybe empowered them. And lastly, it hasn't been published. It's going to a journal. It just got submitted to a journal. We found that it's the parents who were involved in the intervention. We looked at parental stress level was decreased in the parents who were involved in the PASI program. We called it the PASI program. In terms of what's the next step in terms of knowledge translation, this program's available in my infant lab. We're right now designing at Kingston Health Science Center. How do we transition? How do we take it from, we have the research to show us it works. How do we put it into clinical practice? It's not easy, especially if you in a unit where there's no assigned therapist, and that's the reality I'm facing. And so I don't have the answer. We're building, and that hopefully will become a part of a publication of how to implement the PASI program in clinical practice. So not even a publication, it'll be available in the infant lab, freely available. However, if parents who are listening would like to do it, print it out, bring it to the neonatal team and say, could we do this? And who could I work with to help show me? When we did the study, we had a video, we had handouts, and we had one-to-one session. So I think that's needed. I don't think it's something that parents could, they could, But I think it would be nice that the team is aware, parents is doing this, would like to do it, because when parents were doing it, the nurses knew, the unit knew, nurses didn't, kept an eye out.
Right.
To make sure baby was tolerating it. Yeah.
Mm-hmm. So it makes sense, the touching around the mouth and creating positive touch. What I still haven't made the connection on yet is why with the arms and the limbs, what is that doing that could help with feeding?
Okay. So, and that's a tactile kinesthetic.
Yeah.
So, yeah. So oral feeding is beyond the suck, swallow, breathe.
Mm-hmm.
It definitely is dependent on the postural control, the alignment of the trunk. What studies have shown with tactile kinesthetic stimulation, which I didn't present today, is tactile kinesthetic stimulation, that stretching, actually enhances the muscle tone of the infants. Infants who are born early tend to have a bit of low tone, and it's hard to get that midline. So it actually facilitates that, which we think actually translates to them being able to breast or bottle feeding better. And I said, I think I take that back. I know, because we did a study looking just like a tactile kinesthetic intervention, and we actually found it didn't help with sucking, Leah. It helped with the suck swallow coordination, the swallow breathe coordination.
Mm.
And that was done in 2012.
Wow.
Yeah. Yeah. Yeah.
It's all very interesting.
Beyond the mouth. We have to think beyond the mouth. That's why I think if you cannot hold your child,
yeah,
talk to your child, tell your child a story about you, make that connection. Put some of your, and the evidence says it's weak evidence. I'm not saying don't do it, right? But it doesn't hurt the child. I think it can only help. Talk to your child, say stories. If you have some breast milk and you could afford, I know some parents can't afford, depending on the volume, put a bit of breast milk on a little pad, next to your baby's your baby's nose, so they can get the scent of the maternal breast milk.
I think you hit on something so important that often we try to make a direct pathway of, if it's feeding, then it's got to be the mouth muscles. Like you can kind of go, oh yeah, non-nutritive sucking. There's so many things you can kind of justify leading down that path, but talking to your baby to think about like, no, this could actually impact their feeding journey. That's huge.
Yeah. And so, one of my graduate students, Anisha Wong, and I give her credit, she looked at a storytelling intervention with parents who they had occurrences where they couldn't hold their baby because the baby was unstable. And she found that it decreased maternal stress. Now, maternal stress, we know, is related to milk supply.
Yes.
So not only are you creating that bond, but if it's helping you, bond with your child, reduce the parent's stress, I think in turn helps with the milk supply, which in turn will help with the breastfeeding. I think those are the connections we need to make also, right?
Yeah, it's like a web.
The mom and the baby together, and the dad too, right? The dad couldn't. We had fathers participate because skin to skin should be dad too. It should be both.
Right.
Right? It's definitely
And relationship and how that plays a role, because I felt at the end of our NICU stay that one of the positives, because we always tried to find the positive things in NICU. And one of the things that we said, my husband and I, about our long NICU stay is that we felt like we knew Tessa very well. And you get to know them and you build relationship and you see that who this person was, because Tessa was 28 and 1, and she showed us parts of her personality right that within the first 24 hours. We saw things that now her at 12 years old, I'm like, yeah, she still is a very like gross motor skills kid. She likes to move her arms and her legs and all of that connected to, everything. Like it's that web of the
Yeah.
complexities of being human, right?
Yeah, yeah. And we forget that, right? That
Mhm.
babies are humans. If they're having a bad day and
Right,
their stomach hurts, they're not going to want to eat, right? If they're
right,
cold, they're not going to want to eat because they're not comfortable.
right.
There's all these other factors. Yeah.
Mhm. Tasha made this comment from New Brunswick. She said, my youngest was born at 28 weeks, and my Facebook memory today was a post about me trying to do non-nutritive feeding when he was just 20 days old. So I love that because it's full circle for Tasha. So thank you for sharing that. But it leads me into my next question, too, because you talked about non-nutritive sucking on an empty breast.
Mhm, mhm.
Which for me, I have to say, when I heard it, I was like, ooh, like we were a non-pacifier household, but Tessa used a pacifier in NICU that I could settle and be like, it's fine. She'll, and I think it did help her. But when I think of a baby sucking on an empty breast, the alarm that goes off in my head is they're not getting the payoff of milk when they're doing that. And so are we teaching them something that then they have to unlearn?
So that's a very good point. However, I did allude, and the question mark is I think they're still getting traces.
Mm.
We can when mothers are pumping, it is very we know that it's never empty.
Mhm.
There's always some milk traces. And I think actually those little traces are good because it's not this huge flow where when you have that letdown and just flow. So if they're being trained with that, I I I really think it could be beneficial. I that you raise a really good point. That are they making a wrong connection,
Mm.
right? Are they making the wrong connection? Like I'm sucking on this, but I'm not getting any milk. And I
Right.
think the idea, and when we did this study, we always told parents, you're not. The idea is that they're not latching and sucking. So sorry if that's what I made it seem. The idea is that you're putting the baby to breast.
Mm.
And if they open their mouth and they latch and you help facilitate, that's great. If they do 1 or 2, 3 sucks, that's great. But the idea was to have that experience. I always, when I was talking to parents, and when we still talk to parents, it's breastfeeding is hard. It's a training, not only for the infant, but it's also training for the mom. And this non-nutritive sucking on the empty breast, Leah, I always introduce it as it's a good time for you to learn how to even hold the baby, what's a comfortable
Yes.
position,
Mhm.
um, with the chairs, and there's when to do it, and people coming. So when it does come time to breast or bottle feed, that learning curve it has been established. Like, oh, okay,
Yeah.
I
Very
could
good
do it.
point.
And actually, it's anecdotal. We've had parents say, "Oh, I know he's getting milk. Do I say something?" And so I say, "Well, let the nurse know." So they felt like, wow, the first day baby wasn't doing anything, and by day 10, baby's sucking
Right.
and getting some milk. So it's a training, right? And so you're starting that whole training before the team says start the feed.
Mhm. And that leads us into our last question that came from Sandy, who asked a question earlier about kangaroo care. So she was saying, if a parent is doing kangaroo care and the baby is crying and twisting, what kind of is your suggestion there?
So um, I, again, some babies it works or not. So it's that um, static tactile input. Putting your two palm, if you can, right? You're holding one like this, and then this one to contain the
Mm.
baby may help because in the isolette they're swaddled, and then they're not swaddled anymore. So having that static um, input may help.
Mhm.
may help. That static input. We found when we do the interventions, and when I'm training the therapists or my students or even nurses, is when babies start to cry or push, we stop, pull away, and provide static input
Hmm.
and wait and see what happens. That's a suggestion.
Well, thank you so much. Again, I feel like this is such practical advice. You've given people some tools that they can draw on and advocate for themselves and to kind of make that journey. I would even say give confidence
Yep,
to both
exactly.
healthcare providers and families as
Yep.
they try and navigate this journey that is
Yep.
often, like we said, not very straightforward. There's often bumps in the road. And so thank you so much for bringing your wisdom and for sharing some ideas. And if you're like me and you want to go back and rewatch, then feel free to do that. You can see Sandra's presentation again. It will be on our website and YouTube channel. So thank you for being with us today.
Oh, my pleasure, Leah. Thank you. Thank you, everybody, for listening and for being here.
And thank you, everyone, for being here. Like Sandra said, it really does contribute to the conversation when we have people joining us and bringing their own experiences and their questions. So, like I said, if you missed any part of today's session or you want to revisit it, you can find this episode and all past episodes on our YouTube channel and website. And I'm going to put it back up there. It's CanadianPreemies.org. So visit that website. And while you're there, also take a look at all the resources. We have free printables that are sent to NICUs. There's posters, there are brochures offered in several different languages as well. So take a look there. And also, you'll be reminded while you're on the website that CPBF is a charitable organization and that it relies on the generous support of people like you. And so just remember that your donation allows us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. And talking about bright lights, I have to pop this up again. I just want you to be thinking about November. I know it feels like it's a long way off, but it'll be here before you know it. We are planning for the first time the Little Lights Big Hearts Gala. It's going to be awesome. We're going to have food and friends of the preemie community, and it'll be an evening of connection and giving. And of course, it will all be purple wrapped up in heartwarming giving. So start thinking about what you can wear that's purple. Mark that date on your calendar. And the other thing I want you to keep in mind is that you may have someone in your life who could consider being a sponsor for our event. There are lots of great sponsorship opportunities that are up on our website. So again, go to CanadianPreemies.org for all those details, and we will let you know as soon as tickets go on sale for this event. Thank you all for being a part of this very special community. We'll see you next Friday at 1 p.m. Eastern Time for another live edition of Preemies.